Hey everybody, this is David from Mojo Vitality, and a lot of what we do here at Mojo concentrates on pelvic wellness, and today we have the owner and lead therapist at Progressive Pelvis Physical Therapy, Jackie Crowell, joining Dr. Cullison today on the couch to talk about really female pelvic health and wellness and what the crossover between what they do in pelvic floor physical therapy and what we do optimizing hormones in women and vaginal rejuvenation. Of course, Dr. Cullison and his long expertise and experience in serving that type of medicine and what Dr. Jackie does is a great crossover. So sit back and everybody stay tuned to hear two Goliaths of the pelvic health and wellness arena talk about things that's going to blow your mind. Coming up next.
All right, so Jackie Crowell here, owner of Progressive Pelvis Physical Therapy. I'm a pelvic floor physical therapist, and I'm here with Dr. James Cullison, who's board certified in urology and subspecializes and previously did many reconstructive surgeries for female pelvic medicine. And he is now the medical director of Mojo Vitality here in Marietta, just outside of Atlanta. And we're excited to chat today about women's health, pelvic health, and sexual health. So I'm really excited to pick his brain because I get so many of my patients asking me about hormone optimization, as well as how they can improve their sexual health, especially over time in the perimenopause and menopause era of their life. I'm seeing women struggle with having the time with their OBGYNs to talk about some of these topics. And so I'm sure you've seen it in your practice, but now you are experiencing a whole different it's a whole different medical field to be able to spend the time necessary to answer questions, given now that you're in a different setting. So can you tell me a little bit about that and that transition?
Yeah, that's a good point. So your gynecologist, we had a podcast on this earlier, that they have their job to spend time on the typical diagnosis and presentations that are in their guidelines. So they nor us as urologists, you just don't ever seem to find the time to invest in those details and things that you could do to make somebody's sex life better. I mean, it ends up coming down to a small surgery or maybe one prescription or something like that, and you end up doing a lot of the routine stuff that's in your guidelines. So, but to really dive deep in, somebody's hormonal balance or their sexual health or vaginal health or pelvic health, it takes time and a lot of conversation and exploration of and some things work different for some women than others. And in the traditional medicine, and I don't want to get off on talking that down, but it's just not really designed to go in that. That takes, you don't have time to sit in front of somebody and just really dig into their complaints and their needs. So yeah, this has got a different perspective here. So we sit and we talk, and it's one-on-one, and we're not trying to set you up for surgery. We're not trying to fix those pain problems or as much as what somebody might have. Like in the end, they may need a hysterectomy, but we don't even start with those angles. It's really there's specific issues and concerns, or there are those that are actually doing okay, but they want to do better, and they know that they can, and they may have heard it from a friend or something like that. So, So here it's a time investment. When you make an appointment here, we can really explore your issues and do what we can to help, in a safe way.
Yeah, we get a lot of women in our office asking, how can I make my orgasm better? How can I make sex better? I've noticed a difference since I had my baby, or I've noticed a difference since menopause. When you have a woman coming to you wanting a better sex life, what process does that, what does that look like?
Well, it depends on their age range, how my perspective starts. Whether they're close to menopause, perimenopause, or after, or maybe you have somebody that's 35 and they're done with children, or even those that are still cycling and they still might get pregnant. So the starting point would be that. But, if they're, need to find out if it's a problem with pain, is it a problem with interest, the arousal part, or they might be too sensitive, or they might not be becoming lubricated enough. So some of them might just need their hormones serum, their blood work hormones optimized in order to get to the appropriate arousal. Because if you can't ever get that, if you just don't have the interest, it's hard for all the other stuff to kick in during sexual activity. You won't have good sensation, you won't get good lubrication, you won't enjoy it. You're just going through the motions. So it actually starts with the libido and doing what you can to get the arousal phase the best that it can. But then you think the woman that has the great arousal, but then it's just not pleasurable or actually a little irritating to actually be part of it. So, there's different phases of the sex life. But I would have to say, a lot of times I would think of the hormones, not just local hormones, but taking a pill or a patch or something like that to get that optimized, because there's a lot to be gained with that.
Yes. It's been exciting to see. I've been in pelvic health practice for over a decade, and to see the shift in use of estrogen over the past couple of years has been really exciting. But I'm really looking forward to the future of more progesterone and testosterone for women, and women being less fearful of use of hormones. So what have you seen in regards to that as of recently?
So, I trained in the 90s, and it was around 2002, the World Health Organization came out with this, terrifying article. Was it badly written? Was it badly designed? You can get all kind of people sharing their thoughts on that. But in the end, those women in the study were taking Premarin pills, basically, and that was very common back then, that particular. So they linked it to breast cancer, and whether that link was directly related to how that medicine was made, the way that it was given, daily pills, maybe it was flawed, and now they're going back. It's been over 20 years now. Now we're coming back, not me personally, but all kind of investigators thinking, that really did not get the answer that we needed. It really was not proving anything. And so some people think it's because it's a daily pill, and a female's cycle, if you're cycling, that's a 28-day. The hormones are at all kind of different levels there, and giving somebody just a daily pill where you get spikes, I call it the sawtooth pattern, just getting a daily spike, it goes back down, daily spike. So that your body's not used to seeing that, and that could be something with that. It could be the dose, and they'll have them go through the first pass effect of the liver. It could be that. So, and it may be that the hormones then were not bioidentical, which we can talk about in a little bit. So there's a lot of controversy on that. So basically, they're starting over. And what we have learned is that all this dementia and these hip fractures are just getting more and more common as somebody gets older. And, where's this coming from? These quality of life, some people are living, women are living a long time, but their quality of life is terrible. Mm-hmm. So anyway, in the last couple of years, more and more women have seeked out going on some sort of hormone replacement, including testosterone. So this is actually a new game. For most people, never heard of this stuff. But a lot are really nervous. Maybe as we move on today, we can share our information, what we've learned about the safety of going on different types of hormones. There's a lot of excitement in what we can do for a female to make their sex life better, their overall health, exercise abilities, able to get their weight down, and cognitive effects. So there's a lot to be gained by, looking into the hormones. So we're all talking about serum hormones, meaning in the bloodstream, which we can measure with tests.
Absolutely.
Mm-hmm.
And so testosterone in particular can be a big game changer for libido and orgasm strength and capacity. How do you typically, for a woman, administer some testosterone and or progesterone?
Well, progesterone is mostly still used as a pill, and this is just a short part of the progesterone, but that's still a pill that's taken at night. And there's a new now I wouldn't call it a fad, but there's a new interest in giving them micronized progesterone, and that's a story for another day. But a lot of gels, patches, or pellets aren't used with progesterone very much. They deem that the progesterone tablet probably it makes you gets you good sleep and stuff like that. So it's still a nightly pill. So there's not a lot of controversy on that method of administration. But now, testosterone, there's actually a pill form, but I do not recommend that. Even a troche or a throat lounge that you can take, that I don't recommend that. But there's creams, there's shots, which are the cheapest, and then there's pellet inserts. And what I'd say about testosterone is that I'd say that when women get to be about 40, they've lost their baseline testosterone that they had in half. So think of it like this: women at all times compared to all men, they have about 10% of testosterone floating around in their bloodstream. And you'd think, well, this must not be as important. I'd have to say it's the opposite. So its fluctuations are more critical and more felt by the patient because of that small little variation. You know, it's like you had a great big sand pile over there, and you go over there and take a couple of buckets away. Well, you still got a great big sand pile, but you got somebody with a little sand pile, and you take those same 2 buckets away. So with women, they have a 28-day cycle, and so that testosterone is just a baseline. It doesn't have that diurnal 24-hour fluctuation like a man's does. It's this little baseline, and when they get close to ovulation, a couple days before, and theoretically, I never really picked up on this unless you really start talking to a female, but that's sometimes the best days of a female's month. They feel the best.
1,000%. I can relate. Yes.
Yeah. Nobody's ever really. You ever heard anybody talk about that? I mean, guys don't know this. I mean, I can tell you that.
Yeah.
And but yeah, and so sure, of course, their estrogen is very high there. They're building the endometrium of their uterus lining, and then the progesterone starts to go up. But when you ovulate, the estrogen's at its peak, but also the testosterone is too. You can see it. It's just like a little blip on the map right there at the same time, right during ovulation. And it could be part of it. It might double in amount during that time. So giving somebody testosterone now, a female testosterone, it can have a lot of that same feeling that you're just expressing right there. That they want to get out and do things. They sleep great. They're in a great mood. Their sexual arousal is fantastic. So you can get a lot of that by raising the testosterone in a female just ever so slightly. We're not trying to make it like the man's level. That's not it. You're just trying to, we don't know what it was when you were 25. We don't know what it was when you were 18. And we don't know what your receptors are doing either. But just giving somebody cream, I always start with cream sometimes if they're nervous about it, whatever. But I will tell you from a health perspective and risk, nobody has found any. Honestly. And if you give too much, I'm going too far with this, I'm sure, but if you give too much, they might get a little acne breakout or a little hair here and there. I mean, there's a lot of other things that happen when you give them way too much. But just a little too much, you might notice those subtle things, and they're reversible. You can lower the dose or what have you. So, yeah. So anyway,
very safe.
Yes, it's very safe. I'm very comfortable. I would give it to all my friends that are female and family. I would eat it all day long. I feel no risk or concern by doing that, and they've got lots to gain, doing it correctly, And it's easy to monitor as well. But the progesterone, we're talking about whether they've had a hysterectomy or not, and we're getting in the weeds on that. But the dosing on that is, it's titrate. You kind of titrate it. You obviously you don't want to cause any uterine bleeding, but that goes with the estrogen. So anyway, I would say that those two things, mainly the testosterone, has not been explored much. I mean, and that is the easiest to manage in a female.
I've heard some other providers discuss postpartum blues and depression and how it's related to that plummet of hormones after pregnancy and that postpartum period. And if we have a mom who is suffering from some significant postpartum depression and they're not breastfeeding, why not give them some level of hormones to kind of let them level out and improve their mood? I think one thing that a lot of women even don't realize is how much their hormones impact their mood. And so I think that's one of the biggest probably things that you see is that women come back and after starting some HRT, hormone optimization, they notice one of the biggest things that changes is their mood and their energy level. And I want more women to know about this for this one singular reason. Mood is greatly impacted by your hormones, and I think it must be really rewarding to see that.
Oh, it is, and I would say that the unfortunate thing is after pregnancy, and this again you can't test it, is that your hormone levels got really high. Some women love pregnancy. I mean, they just feel like they're their best, And in the human body, what is unfortunate is that whenever it sees a lot of stuff, it's like, that's a lot. What's going on here? And so your body, all the cells in your body will down-regulate the receptors, or they'll modify them so that it will not react or respond so much to the exposure of a signaling agent or a hormone. No, not just sex hormones, but that could be anything. And so, when you've been through pregnancy, they've been really high. And, and most of the time that makes you feel really good. But during this time, your receptors might be down-regulating some. So where then it went back to where 2 or 3 weeks later it went back to where it was. Well, now your receptors haven't recuperated. They're still desensitized or involuted or whatever it does. And now your normal level of hormones aren't doing what they used to.
I see.
So unfortunately, we can't fix that. Your body has to upregulate over time. Realize, this body's used to a little more reaction to that. So then it starts up. So testosterone during that time is perfectly safe. If you wanted to go on some estrogen, you could. The key is you don't want to do that when you know you're going to get pregnant again. You want to really make sure that you haven't done it. Now, that would be the downside of that. But there wouldn't be harm physically if you're doing that. And testosterone, again, would be the easiest.
Yeah. The other thing that's really safe, and we've recommended our practice, is DHEA. And it's actually available over the counter. Bonafide is a product that Reverie, they sell Reverie, and it's a suppository. But there's also another company that sometimes I've recommended called Bezwecken, and you can get them online. But tell us a little bit about DHEA and how it benefits the vaginal canal.
Yes. You can get those sources. You can get them off Amazon. I mean, they've got, but now there's the compound pharmacies have multiple doses of that. And you can get some higher doses and play with it a little bit. And so DHEA is one of the androgens. There's like 5 different androgens that a female can have. Most of them made by the adrenal gland, but your ovaries make testosterone in that line of products too. And DHEA is at the beginning of the flow of how sex hormones are made. So you start with a cholesterol molecule, and it gets certain enzymes that make it into the next thing and the next things. Well, DHEA is early in that pathway. And as enzymes keep changing it, then you got androstenedione is another one, then you finally get testosterone. Then, it can go off another route. Then you get another enzyme that'll make it into estradiol, then later estratriol. So DHEA is up there earlier in the path. So it's capable of being cleaved and made by your body into estrogen and testosterone, both, you see. So, and it's to mimic what your adrenal gland makes. The men have it too. And so there's DHEA creams, there's DHEA tablets, and there's vaginal DHEA. Now, I'm a fan of the DHEA vaginally. Again, the DHEA by mouth, now you're asking again for estrogen by mouth. I'm just not a fan of that. But, so there's testosterone receptors and estrogen receptors in the vaginal lining. There's probably more testosterone receptors towards the end of the vagina. So in the medical terms, we say proximal and distal, right? So the proximal vagina would be the deep vagina, and the more distal vagina would be the outer. So the outer 1/3 of the vagina, those embryological parts are analogous to a male. So they theoretically also have more testosterone, or they have the ability to upregulate to have more testosterone receptors, because those cells came from before 9 weeks of a fetus that had the same parts, and ready to become either one. You see. So anyway, so if you administer DHEA, it provides some testosterone and some estrogen, both. You're kind of getting a little bit of both. both worlds. And so, and we can go into this a little more in a minute, but in basic terms, the estrogen for vaginal health will make the epithelium, the lining, become thicker, more blood flow. You'll start making more secretions. It'll make it less sensitive or irritating during sexual activity. As it does that, your pH will be lower, which prevents infections. So with the DHEA intravaginal, back to what we were talking about, is the estrogen part will thicken the epithelial layer to get the moisture, secretions. Now, will it help your central nervous system in the arousal phase? No. It's just basically local tissue, thickening and lactobacillus. We need more lactobacillus all over us. It's a powerful organism, and it's symbiotic with us, so it's not harmful, it's not pathogenic. So you want that in the vagina, lots of it. It feeds off the glycogen made by the sloughing cells, and you get more and more of those through the vagina the more estrogen you've had, and thicken that epithelium comes, and then you get more lactobacillus, and they make lactic acid and all that. So that is a healthy vaginal environment, is what you want. And if you get close to menopause, or if you had to have your ovaries removed because of endometriosis or what it may be, then over time you're going to see that your vaginal lining will become thin, frail, non-compliant, more rigid, less secretions. Sex is hard to enjoy. And DHEA is one way of doing it. We've had some that like that, some not. Some have to just go to the estrogen cream or some estrogen suppository. It probably does a little more, but it doesn't have the testosterone effect. The testosterone part to the receptors probably does help with the part of the arousal, the sensation, maybe that. I don't think estrogen in the vagina so much makes the sexual sensation that much better. It can help because of what it did to the lining, but the testosterone probably can make orgasm, getting wet, and just the enjoyment during sexual activity probably will increase it. Now it's hard to do a study on that. You think about it, that's a subjective, type thing. But I've done that before, so I've had success. I've had women just come in and say, "Man, that fixed me." I mean, we've tried everything, but that was it. Maybe a testosterone cream. There's an appropriate one you use. They don't make testosterone suppositories for the female, but you can get a cream that you can apply. Yeah.
Okay. Sex is so complex. You've got the mind and the body working together. And sometimes we have to treat all the things. I know that at pelvic floor therapy, we see women who want, to achieve stronger orgasm, and we're working on their pelvic floor strength for that. We often refer to sex therapists and sex counselors to assist in the mind component, or we're recommending resources, and you've referred to medications and hormone optimization, but there's also devices that can help optimize in the vaginal canal and ease some of the symptoms associated with menopause. Tell us a little bit about what Mojo offers in that regard.
Okay. So I would say a good thing that a female can remember, that there's really two things that will optimize your sexual experience from the vagina mucosa standpoint. And that's what we just talked about, some sort of local hormone, sex hormone replacement or optimization, DHEA, testosterone, or estrogen. They come in many different forms. Or you can do something that actually, a procedure to actually build that tissue. That's the Mona Lisa touch. It is not new. I think it came out in this country a decade or more ago, just maybe 2012, maybe. And I've been doing it for years. And so I'm not going to tell anything that you can't find on the internet already, but I'll tell you about my experience and what I'm a firm believer in. And that is, that laser makes a spray of little CO2 laser cuts. It almost looks like you're spray painting in spots. That's the way I call it. And you do that all the way to the back of the vagina, circumferentially all the way out to the front, and then you have an external handpiece that treats the introitus underneath the urethra, all around underneath the clitoral area, the labia minora. I've never done the majora, but I've heard some people have. But it basically, it just leaves this little pattern of tiny little cuts. A little bit. It's tolerable. You can sit there and have a conversation with me while I'm doing it, And it takes about 5 minutes. And what happens is, for about a couple of days you get a little clear vaginal discharge. Some people complain it's a little bit of itching, but not debilitating typically. And what happens is your body brings in this healing tissue, healing stuff, molecules, and rebuild signaling that you'll start getting that thicker layer. So just in itself, without the hormones, you can start seeing that same response. And they've actually done biopsies to prove this. It's not theoretical. I mean, that tissue, that epithelial layer gets thicker, starts making more secretions, becomes more compliant. So people who sign up for Mona Lisa laser are not the ones who want to make everything tighter. You're looking for, that's not what that does. It'll actually make the tissue more compliant, so it can help with improved sensation, better sexual experience, and just bringing the pH back where it's supposed to be. And you can do that in combination with the hormone locally. And that is, if you want to do both, that really, if you're trying to just get the best, you do both of them. And I say the hormone's different from person to person what works. So we've had good success with it. I used to quote an 80% success rate. And when I'd say that, those that came in would get anywhere between 3 and 5 treatments. 3 was the way it was reported, and some people needed a little bit more. I'd let the patient decide. They'd come in and get the minimum 3. You have to do the 3 because the first one, the setting, is a special kind of setting to set the stage for the next 2. So when I said 80%, I mean, first of all, those who came for the first, they all wanted to come back to get all 3. After about the second one, they're like, wow, I mean, I'm starting to notice a difference here. It's not grand in two treatments, but it's noticeable. It's an improvement. And so then after 3, some want to get 5, and the 3 they were doing good, but some are like, y'all just want to keep going further with this because you can't really do it too much, as long as you're waiting 6 weeks between, And then we'd get people coming to get it twice a year just to keep the maintenance up. And in the end, it could end up being cheaper than all that the topical stuff, because if you just get your tissue rehabilitated and then you can maintain it with the treatment now and then, that's just a good long-term plan. That's very cost-effective. It's absolute money up front. So we've got good success with that. That's the only. They have some other devices out there that are a lot more complicated that probably do more than just the superficial layer. I would say you would be more of an expert in that department. But if you're really wanting to get the outer tissue thickened, secretions, the better sensitivity, where you just change the mucosal lining, those are the only 2 angles, really, directions to go to get that back.
Okay. And I want to touch on, before we leave hormones and go more towards libido, is talking about the value of estrogen as we age, and the fact that women should really be using it until they die to prevent a lot of the UTIs that we see later in life. Can you speak to that? You practiced so long in urology.
You can. I mean, men don't have very much estrogen, so it's quite obvious that I believe that women have better hair and skin, dazzling, and I think a lot of that has to do with that angle there. So it's self-confidence and looks, and it has a lot to do. It stinks to let it fall off and then have to build it back up. So at some point, even in your middle-age years, you're done having children, and you're 35 or 40, and we have women come in and get, replacement therapy, and we'll put a little testosterone and estrogen, it can vary, but the estrogen for sexual health and preventing urinary tract infections and pelvic health in general, it's essential in keeping that tissue lively, youthful, whatnot. Testosterone won't do that. Now, testosterone will do other things, but not that. And as far as like mood and cognitive things, the estrogen and testosterone as well, but the estrogen plays a big part in that. I mean, there's receptors up there for that. And it's not, the blood-brain barrier does not prevent that from going in there and doing its thing. So it's a slow decline, and it starts early. I mean, your estrogen levels are going down, and your testosterone levels are going down in your middle-aged years, and you're just waiting for them to turn off before you start taking them. I mean, why'd you do that? I mean, so if you do it correctly and do the right amount, I mean, then you're really maintaining healthy tissue all over your joints. They need the sex hormones in addition to other signaling agents to keep youthful and lively. And then you're right, the arousal phases that I guess we'll talk about in a minute, and the different stages of sex, arousal, maintaining the good sensation, and then orgasm, things like that. I mean, that's 3 different phases there. So the first and the last are the most complicated. Yeah, you just don't realize what you're missing out on. In fact, women, right now, really, very few of them experience it because we've robbed them of it for 20 years. And so I would highly recommend that. It would be great if you and I have spoken this before, if we all, even in men, you got a baseline level of what you are, say, when you're 22. You're done with puberty, you got all that behind you, and it's starting to level out now. What was it then? What was your FSH and LH, and what was your, even all your others, as I said, the other androstenedione and the DHEA, and, what was your estradiol, what was your estradiol for that matter, what was your testosterone. It'd be neat if we could have that panel to compare it to later. And the stress, you were talking about the arousal, normal vaginal health, and lots of stress can play out big. And we're in the country now where we're multitasking. We don't know how to do anything without multitasking. And that, and I always go back to the fight or flight. Most people remember that from high school. If you were in sexual activity and just felt great, man and woman, or partners, whoever, if someone outside your house shot a shotgun, all the blood flow that went down there it's gone. It's gone immediately. So when you're stressed, you got a lot of things going through your head, and you're focusing. You're taken away from your own ovaries, and men are taken away from their own testicles to even make that stuff. You're killing it over time. And of course, during the arousal phase, it's completely impacted by that. So addressing those things earlier, I would have to say, will help you in the long run. I mean, you can restore and get a lot of it back, but you sure didn't miss out on a lot.
Yeah. I love how Mojo offers testing, this hormonal testing, so cheaply, and they can come in and get a consult with you for really inexpensive. $50 for a consult is such a phenomenal deal, and I think tracking over time your hormone levels is a very well-worthy investment, and so I love that. I love that you also offer, so in addition to hormones and the laser Mona Lisa, you guys also offer libido, like the PT-141 you were telling me about, and some other things that will help pique your interest if that first part is a struggle.
Yeah, that's tough. You want to optimize your serum hormones first, because if you're circulating testosterone levels and estrogen levels weren't optimized or on par, these other ones that we're going to talk about are very helpful, but you're really a little bit wasting your time. You really ought to consider optimizing those first and then do that. Yes, PT-141 was FDA approved not too long ago, and it's a little peptide molecule, very safe. And it affects the central nervous system. We're not doing anything locally to your private. So it definitely enhances the arousal phase. So it's FDA approved for female hyposexual disorder. But the men and women are both analogous, so both of them can take this. So you can get it in a nasal spray, you can get it in a shot, a little tiny needle we're talking about, sub-Q. And actually a cream and a troche or a throat lounge. So each one of those work. The shot works pretty in 30 minutes. It's almost 30 minutes to an hour thing. So but the lounges and the cream thing, and the nasal spray, people report it works in 2 hours. Some people might be an hour. So you kind of have to figure out how your own body deals with it and the dose as well. So, but there's no risk in that. I mean, honestly, you just use that on the spot. You don't do that every day. It's an on the spot thing that really increases arousal, interest.
Okay.
And now when you do that, you got to get it right from the beginning. It's like a rocket ship, If it's a little off course before it gets to the moon, they can fix it. But if it's off course right here at the beginning, then the whole trip's lost. So the arousal phase is so important to start sending blood flow to your private parts. I mean, you've got to be in there, and things relax. You know, some women can't relax enough. You know, they've already got the wheels, the cogs turning. You know, they can't relax. So you need the arousal phase to be very good. You know, and that was the guys that used to go and get the Viagra and Cialis when it came out, which worked fantastic. That was worthless if they couldn't get past the stress and they just didn't even want to think about the arousal. But you got to be in the mood. That's why I said you can't be sitting there watching 60 Minutes and you take Viagra and all of a sudden everything's great. It doesn't work that way. Yeah. So you need, and that's a very complicated thing. There are some hypothalamus, and you're upstairs here. There's a lot of organs that play a role in that. It's not well understood. So the PT141, it's got another name. I can't pronounce its second name. It starts with a B, bremelanide or something like that. I apologize to the audience. It's too complicated to say, so I say a scientific name. So yeah, that's one. That's one that hardly anybody knows about. Honestly, think about it. I mean, I've never heard any guy ever talk about it, or female in my office. You know, we end up offering it to them. So a lot of compounding pharmacies, you have to get from them. You can't go to your local pharmacy and get it. You know?
So I love this very comprehensive approach you have to sexual health and addressing it. And going so far as the step before even all of this, the peaking of the interest, is some of the weight loss stuff that you guys do to really help people feel their best and look their best and have that confidence. Because I think that confidence is really a precursor to being interested as well, for themselves and their partner. Yeah,
self-image, your self-love, your self-image certainly would have a lot of impact on your arousal and your whole sexual life. To be honest with you, if you don't have good self-image, it's just hard to even get there. So, there's multiple ways that Mojo approaches that, and that's a big topic there that has a lot of ways to address it. And we have weight loss. Well, first of all, we will always coach you on dieting, and what I feel, a combination of things for dieting to lose weight as well as living a long time, longevity. There's a lot of good science behind all that. So we would certainly want to coach you on that and exercise, and then we can augment that with, weight loss medications, peptide therapy, we call it. That I consider to be safe. We don't do anything that I hear that I consider to be unsafe, that I wouldn't do to my own mother or wife or something like that, honestly. So we have a big approach to that. That's a large approach. So, and now that you say that, since we've been open, I mean, I guess that's the consult that they come for. They'll have a lot of things on there they're interested in. I'm like, okay, I saw that you're really interested in all this stuff, but really give me two to work with that's really interesting. So it always ends up being the weight loss first. I mean, you know what? I mean, everybody would like to lose weight, so they may not have realized until they were filling out that questionnaire, like, I really would like to lose some weight, because then all this other stuff.
Right.
And that ends up what's happening here. We get them started on that, and I remind them, like, we just spent 45 minutes with you, so we're going to have to come back another time, but at least we can get some blood work, after I've talked to you, what you feel might be best, the pound you need, and then let's get you losing some weight. And we can begin working on some of this stuff. Some of it doesn't require blood work and full analysis. I can just do it,
Right.
But you're right. The losing weight is very popular. I mean, it's on everybody's radar to some degree.
And I think it's a really great square one to start with, because it does. You're working on their health from a variety of angles when you're getting them to an optimal weight range. And exercise is inevitably a component of that. And what we know about libido is that exercise is a major factor when you're getting that blood pumping thoroughly and often. It definitely helps with your libido. It helps with your pelvic floor strength. It helps with getting blood flow down there. And that's always one of the education points I make sure my patients know, is that exercise is the number one, or is a huge component of libido and better sex. So, I
would go on to say that leg exercises, resistant training on the legs, they have found that in women and men, it'll raise your own production of testosterone naturally. And of course, the cardiovascular part, yes, because the blood flow to the areas that you need will only improve, of course, and that's why we tell people don't smoke and don't try not to get your blood pressure up to where you have to take blood pressure medicine, because it works against you in all those ways, you know.
Yes. So we've talked a lot about female sexual health, female hormone health. I think one other thing that my patients would be interested in is knowing how this all ties in as well with stress urinary incontinence, which the risk increases as we age. And I have often, of course, worked with them on their pelvic floor strength, but often recommend and refer out for hormone therapy as well. And you may have other methods of treatment for stress urinary incontinence as well.
Yeah, so reflecting on the parts that we already talked about, so with what you do with the pelvic floor, the musculature, the fascial planes, some of the network of material that are around the vagina and the pelvis, when you have optimized your estrogen circulation, what's circulating your body, I would have to say that it even makes they can get even more out of what you do is to have that optimized. So I just want to put that backwards up and pull that plug up. Now, what was the other question again?
Well, I think that you were telling me about the Mona Lisa being also helpful for stress urinary incontinence.
Yeah, so the coaching that you all do for stress urinary incontinence is very helpful. Probably goes further than us, but I always tell women that, you know, with the stress urinary incontinence and even the urgency incontinence, that, you know, after they've had with their first pregnancy, and then immediately after that first pregnancy and delivery, is that every time they urinate, every single time, you stop your stream really fast halfway through it, every time. You'll get in the habit of doing it so much that you don't even know you do it anymore. And some people are born doing that anyway. Some women will urinate and they cut the stream off, and I don't know whether they think or how it got to be that, then they do the second half of the stream, you know. That action there alone, just stopping as fast as you can, every time you urinate, from then on out, that goes a long way. That doesn't cost anything. You'll do it enough to where you just forget, you know.
Yeah.
That, and then the exercises and things that you all coach. I mean, we coached it in a certain way.
Can I put it on pause and mention? So this is so interesting. So in our pelvic floor classes, they talk specifically about that, stopping and starting your stream and how it's not good for you, and drill that in.
You can't do that for those that are having pelvic pain. So if they're having pelvic discomfort, you don't want, and that's also why we only do it once. Like some people just doing that thing like that.
Yeah.
But if some people have pelvic problems like pain or irritation, they've done studies. You all have probably different literature than us, but there's studies that, you know, like interstitial cystitis and all those people that we have, or inflamed pelvis and whatnot, or irritable bowel that's so bad that you can't tell whether it's blood or not. That Kegels and pelvic floor exercises you cannot do. It's only relaxation techniques. So, but for stress incontinence, that in itself, in this little ball, yes.
So I've heard it confuses the bladder, like, because when you relax your pelvic floor, that tells your bladder to contract, right? When you sit down and you relax, then that's when your bladder contracts. But if you're sitting down and you're relaxed, then it's getting a confusing message.
No, well, you know, the ladies that we have to tell them to relax their pelvic floor in order to initiate void, because the act of voiding is not your bladder squeezing first; it's the external sphincter. This will not squeeze until this thing has noticed a relaxation. This can't squeeze. It is that's built into human function. That concert right there.
Right.
So,
and a lot of people I see have a discoordination.
Yeah. Dyssynergia, that's right. Mm-hmm. And so you can see people that have like a damage to their perineal nerve and they have a spasm of this, they'll never be able to generate a bladder contraction because they can't, that concert has to happen.
Right.
So I guess the study I would say to you, so that's a pelvic floor dysfunction patient right there.
Right.
You know, they can't relax that. So you would not want to tell them.
Yeah.
But a person that's just run-of-the-mill stress incontinence that doesn't have a complex problem going on with their pelvis, yeah, we do that because they've done studies that neurologically, that action of doing that, it doesn't do anything directly to the bladder, but neurologically it starts building a reflex response that makes the bladder calm down and whatnot. So, and actually hold more urine. But no, it's very strong in the urology literature for just stress incontinence or overactive bladder without some complex pain issue or irritation, that it will cut down on their leakage for sure. But you know the old thing, a female shouldn't hold their urine, like squeeze that down. That's different. Yeah, you don't want
we often advise them to work on that contraction on the way to the restroom if they have urge incontinence, but not when they're actually sitting. But yeah, it's interesting to hear I'll have to look at some of this research.
Some of it's confounding. It's just like telling somebody don't eat a lot of protein, because when you eat way too much protein, then you get too much insulin growth factor and you get too much growth hormone. And, you know, that's bad for you. It'll give you cancer. Then you're like, well, wait a minute, that's also the things that can keep you young and all that. So I see a literature that doesn't line up, you know, and it's compound. But, I mean, we can leave that part out if you want, but that has been, you know, that's what our nurse and all of our doctors would coach, you know, that stopping one time and doing it multiple times, I think creates kind of a tetany or spasm like. I just don't think it's as good, because relaxing it is just as important as squeezing it, you know. So
right.
Well, anyway, I don't know where to go from there.
Sorry, I definitely okay.
Get it back on.
I never stopped.
So
he's going to use some of that, you know.
That's okay. That's okay. So yeah, we'll figure it out. But so wrapping up, as far as stress urinary incontinence, what Mojo offers is a variety of things, from hormone help as well as Mona Lisa laser. And so there's a lot of options that one has when they come to Mojo in regards to the stress urinary incontinence as well. But I think above anything else, what you guys offer and do so well is education and taking the time with your patients to help them understand what their options are and what they need to look at for the future, not just for the present, but for the future.
Well, that's what I tell everybody at the end. The ultimate goal is longevity and a great health span. Everybody wants to talk about now, just a good quality of life for a long period of time. And, you know, you don't want to be a short fuse. I mean, if I gave a female just tons of testosterone, they came in, they're gonna love me to death. But that's not a good long-term plan. And then you later on are gonna have problems with that. So yeah, it's everything that we can think of that'll make you live a long time, and some of the sexual health will come naturally with that, just because you're taking care of yourself. And so yeah, we'll sit down, and you know, people have different interests, and we will address those interests. But in the end, the ultimate goal is just being awesome. I mean, seriously, I truly believe there's all kind of ways to do that, and I can help you do it at Mojo for sure.
Well, that's really exciting. Thanks for taking some time to talk to my patient specifically today, Dr. Cullison. JC, he goes by at Mojo, and